Words, thank you organizer, entire team, Bansi and organizing team of diabetes. It's good to see many people around here. Always a fascinating to be on this side of podium. Long time we meeting with each other and dissecting medical things. So I'm going to talk on topics we just debating about generic. Here we have got one relatively newer in the sense Evogliptin. Before I start, I would like to know how many of you present here have used Evogliptin in your clinical practice? Quite good. That's great. So you are aware about that. Now let me become a devil's advocate, to be very frank, to tell you where is the evidence. So we have got one cheaper DPP-4 inhibitor, which is an innovator product branded by Indian pharma company. It's available in the market. You have got number of DPP-4 inhibitor. You know, the second highest number of DPP-4 inhibitor is available in India after the Japan. At the moment, Japan has got 15 DPP-4 inhibitor. You would be surprised to know. All are selling good. That is surprising. And India is the second. DPP-4 inhibitor is going to remain, despite all evidence at the moment with SGLT2 inhibitor. Please, let me revise you. When it comes to glucose reduction, the SGLT2 inhibitor do have huge evidence with regard to protecting heart and kidney. But when it comes to glucose lowering, DPP-4 inhibitor has never ever been beaten by even SGLT2 inhibitor. That's the fact. I wrote one editorial on this DPP-4 and SGLT2, which will be published on 14th of June next month in World Journal of Diabetes, looking into where are the DPP-4 inhibitor in the SGLT2 era. So let's look on this particular evolving gliptins named Evogliptin. What is the promise and potential of this newer, cheaper, it's not a generic, this is an innovator, cheaper DPP-4 inhibitor. Now, you know the evolution of different DPP-4 inhibitors. Sitagliptin was first to get FDA approval in 2006, and Evogliptin was brought to India from South Korea, as you can see, was given DCGI approval in 2018. It is available in many countries now, many South American countries, including Brazil, Russia, of course in India, Japan, North, South Korea, everywhere it is available. The beauty of this molecule lies with the fact that this molecule was given approval with a hardcore evidence, unlike another cheaper variations, DPP-4 inhibitor, which is available in India, named Tenaligliptin. I have no grudges whatsoever to tell you that Tenaligliptin has got minimalistic data when it comes to glucose control. Although when India had Tenaligliptin, DCGI had the approval, we didn't have that much data, but of late Tenaligliptin has generated now head-to-head evidence even versus Sitagliptin. But this molecule, Evogliptin, born after fighting a 5 double-blind randomized controlled trial. In 4 trials, they fought with Sitagliptin, and in 1 trial, they fought with Linagliptin, and it came neutral. There was no difference when it comes to glucose lowering. So what is this molecule is all about? Let me quickly take you through some pharmacology. So for DPP-4 inhibitor, just a recapitulation, you must have heard this. This is X-ray crystallographic picture of DPP-4 substrate, and all DPP-4 has to get bound to the two orange color prime. It's called S1 and S2. All DPP-4 needs to get its attachment to the DPP-4 enzyme through S2 and S1. Now, if the DPP-4 has got any additional ability to get anchored into either S1 prime or S2 prime, they are called class 1, class 2, and if they are blocking even S2 extensive arm of the DPP-4, they are classified as a class 3 DPP-4 inhibitor. So this is the modern classification of DPP-4 inhibitor. But it's mandatory that you need to get anchored to S1 and S2. Now, even if you have anchored into an additional binding site like S2 extensive, and you are classified as a class 3 DPP-4 inhibitor, you can see sitagliptin, tenaligliptin, and evogliptin are class 3 DPP-4 inhibitor because they binds to additional S2 extensive surface of DPP-4 enzyme. Now, theoretically, you might assume that all three would be similar because they are binding to additional substrate of DPP-4, but that's not the case. It depends upon the binding association and dissociation that makes a quality of DPP-4 inhibition. I will tell you that despite that they all are class 3, but there is a difference between 3 DPP-4 inhibitor as far as DPP-4 inhibition is concerned. Now let's look into how selective it is, because to choose a DPP-4 inhibitor, remember that treating diabetes is not a 7 days, 10 days antibiotic course, and even if it has got some off-label side effect, it won't be manifested in such a short span of time. But when you're treating diabetes for entire life and using a drug, you must know the off-target side effect of the drug. Now, this is important because remember that while controlling blood glucose, you need to inhibit DPP-4, but not the other DPP substrate, because other DPP-4 are physiologically required in human body for a normal homeostasis. And therefore, if you want to control glucose, you want to selectively block only the fourth enzyme, that is DPP-4. You don't need to block other enzymes like DPP-8 and 9, because in preclinical studies, in animal studies, binding to other DPP enzymes like DPP-8 and 9 was associated with different side effects. Therefore, the scientists tried to bring a selective, or you can see super selective DPP-4 inhibitor. When it comes to evogliptin, they are looks to be the ideal, and they are at par with the US FDA approved DPP-4 inhibitor like sitagliptin and linagliptin, and it is far selective than vildagliptin and sexagliptin and even tenaligliptin, as you can see here, with regard to DPP-4 versus other DPP enzyme, include DPP-8 and DPP-9. As I said, selectivity is important, and the least selective DPP-4 inhibitor is, please remember, is vildagliptin and followed by sexagliptin. Now, you might say, then what is the difference between these DPP-4 with regard to selectivity? This is one of the reasons as to why the vildagliptin has unfortunately been associated with highest skin reaction. Remember, the vildagliptin is not a US FDA approved drug. That is one single important reason as to why US FDA did not approve vildagliptin pending 12 years of petition from Novartis. Remember, Novartis is a European-based company, and they have got a EMA approval, but not a US FDA approval. Now let's look into their pharmacokinetic, important to know, because you need to know where from the drug is excreted, and therefore you need to reduce the dose in a different end organ damage, in particular kidney and liver. Evogliptin has got primarily hepatic excretion and very less renal, and they have been studied in patients with kidney disease and liver disease, and this is the study done in patients with kidney disease. It was published in one of the highest impact factor journal in the world. You can see in DOME in 2017. And they actually looked whether you need to reduce the dose of evogliptin in patients with different degree of renal dysfunction. And the study suggested that you don't need to reduce the dose. The only caveat of these kind of trial, which I always take into a face value, that they have got a very less number of patients in these kind of trial. But this is similar data is there with sitagliptin and linagliptin as well. You don't get a large number of patients in such a PK/PD study. Similarly, you have got this molecule, evogliptin, has got data in patients with liver disease, and they have been recommended to be used in mild to moderate. Remember, none of the anti-diabetic drug is currently allowed in patients with child PUF class C, means severe hepatic dysfunction. Insulin is the only answer. But you can use in mild to moderate patients without any dose, lessening in patients with mild to moderate liver disease. Now let's come to the clinical science. As a clinician, that's fine with pharmacology. Where is the evidence? You can see, unlike other competitive DPP-4 inhibitor in India, it has undergone a massive development program, phase 1 to 2 to 3, and you can see number of, I'm not going to bore you with all the studies. I will catch up on only the active comparator trial. Of course, you will beat a placebo. That's not the point. You need to have a head-to-head trial with US FDA approved drug. So I have chosen few studies. You can see there are 6 studies, of which 5 study is a head-to-head trial of evogliptin, done 4 with sitagliptin and 1 with linagliptin, and first drug is against placebo, upon which they got the approval in the Korea, and then it was brought to India by the Alchem. So quickly look into the data. This is the first study upon which they got the approval. Look at their publication in DOME in 2017, and they shown a superior reduction in HbA1c versus placebo. Not a rocket science, expected. However, this study get them the approval for the treatment in type 2 diabetes. The second study is a Brazilian study. You can see here, this was for Brazilian approval, and in this study, Brazilian people said do a study head-to-head with sitagliptin, and this is a double-blind. Remember, all these 5 trials are double-blind randomized controlled trial. It's not an observational study. It's done in any registry base or in any private hospital. These are double-blind randomized multicentric trial. So this is a Brazilian trial that found evogliptin is as good as sitagliptin when it comes to HbA1c lowering, and they got approval in Brazil from this particular trial. Third study, this is interesting. This is a study that compared evogliptin with linagliptin head-to-head. It's a double-blind randomized controlled trial, and looked for other endpoint. And the primary efficacy of endpoint of this study was to look for glycemic variability between linagliptin and evogliptin. You can see head-to-head trial, first 12 weeks of double-blind, and then open label, evogliptin 5 milligram in 100 patients, linagliptin 5 milligram in another arm. The primary efficacy endpoint was, CGMS data, because we are looking for glycemic variability. And here is the result. You can see there was no difference between linagliptin and evogliptin in this head-to-head trial. This is the HbA1c lowering effect. I'm not reading into numerical. If you see numerically, it was better with evogliptin compared to even linagliptin. But I'm a people of science, believes in statistics. Numericals doesn't matter. If your p-value is not significant, you are drawn. So finally, evogliptin was as good as linagliptin when it comes to HbA1c lowering. Now, if you see the glycemic variability index, be it MAGE or be it a standard deviation of the glucose excursion, again, statistically, there was no difference between evogliptin and linagliptin. But again, if you are a little bit biased with numericals, it was even better with evogliptin compared to linagliptin. And this paper is recently published in DOME again, this evergreen study. Now let me take you a few studies that was done in a background metformin therapy, patient failing on glucose control on only metformin monotherapy, and then were either added evogliptin or sitagliptin, and here is the result. So this was the first head-to-head study between sitagliptin on a background metformin therapy, and you can see there was no difference in HbA1c lowering between, so the lower one p-value is difference between 2, which is insignificant, suggesting that adding either evogliptin or sitagliptin, remember this is not a generic sitagliptin, this is innovator Januvia brand from MSD was compared head-on. There was no difference in the p-value when it comes to HbA1c lowering between two DPP-4 inhibitors. This is Indian study. The DCGI also asked for a head-to-head trial, and they compared head-on with sitagliptin 100 milligram, and you can see both lowered HbA1c very nicely. But when it comes to comparison between evogliptin and sitagliptin in Indian patient, there was no difference in HbA1c lowering. This is another head-to-head study, again on a background metformin, added either sitagliptin or evogliptin. This was done in Korea and Russia, and there was no difference in HbA1c lowering. So this is the fourth head-to-head trial between sitagliptin and evogliptin before it was launched, in India. So to summarize, there were 5 matches played. This is a summary slide for you. The 4 matches with sitagliptin head-on, double-blind randomized controlled trial, 1 versus linagliptin, and the end result is there was draw. Now the point is, if you have got a drug which is cheaper than the innovator drugs, both are innovator, as I said, and both the drugs has got similar efficacy and safety, one can challenge that why not one should use a cheaper drug compared to the costlier drug. But there is a catch behind that. Now, this is a slide to understand how to use different DPP-4 inhibitor. And this is a master slide in front of you to understand what's the difference between different DPP-4 inhibitors. As you can see, we have got this 7 DPP-4 inhibitor right now available in India. When you are choosing a DPP-4 inhibitor, the first and foremost important point is you need to know how much DPP-4 is inhibited by the drug. A drug like DPP-4 inhibitor has to inhibit DPP-4 by at least 80% to have a sustained DPP-4 inhibition, to have a sustained glucose lowering. Now in this row, the first row, you can see 2 drug unfortunately is somewhere has got a questionable DPP-4 inhibition. Is one, the worst was with the tenaligliptin. You can go through the Japanese PMDA approval, and it was maximum 65% with tenaligliptin, as if you compared with other DPP-4 inhibitors. When you're looking into selectivity, as I said, you don't need to inhibit other DPP enzymes to avoid untowards off-level side effect. You can see some drugs are pretty non-specific, and especially vildagliptin, tenali, and sexagliptin are non-specific DPP-4 inhibitor. There's no doubt about that. Dosing, whether you need once daily, and vildagliptin is only exception where it needs to be used twice daily. Many of you might be thinking that there is a vildagliptin once daily available in market. I failed to understand how come this drug was approved, and I'm responsibly telling you in this podium through the Diabetes India that there is no study done with vildagliptin 100 milligram once daily. And also I would like to tell you that actually Novartis made vildagliptin 100 milligram 20 years back, and they asked for FDA approval, but FDA thrown them out and said go back, bring a 50 milligram twice daily. You know why? Because 100 milligram vildagliptin was causing a severe increase in liver enzymes, including hepatitis and jaundice, and therefore the drug was divided into 50 milligram twice daily. Sudden, I'm now seeing the people are back with the drug which was actually banned 10 to 12 years back by the FDA. I have no word to express when someone comes with me to say, sir, we have got vildagliptin 100 milligram. There is no evidence. I'd be happy to see where from they have DCGI got them approval. Dose alteration in renal disease. You don't need to reduce the dose of certain DPP-4 inhibitor. The linagliptin is well known to you, and also evogliptin, there you don't need to reduce the dose. Similarly with the tenaligliptin. In the liver disease, of course, vildagliptin is contraindicated in any degree of hepatic dysfunction. So if you have got even a patient with NAFLD with a increased liver enzyme, on paper you are not supposed to prescribe a vildagliptin if SCPT is 3 times higher than the normal. And of course, you can't use any drug in severe hepatic deficiency. HbA1c lowering, you can see I have put the reference as a sitagliptin. If you have got a head-to-head, they all looks to be pretty same. There may be 0.1, 0.2% difference amongst a few head-to-head trial, but by and large they are same. QT prolongation, cardiac safety is of utmost importance, and tenaligliptin is the outlier, and that because they do increases the QT interval prolongation. Even in a dose which are used clinically, if you read the paper, you know, the highest, driver of QT prolongation in a diabetic patient is hypoglycemia. So if you have got a patient on sulfonylurea and you are using even a teneligliptin 20 milligram, be careful that it might cause QT prolongation, because SU will cause hypoglycemia, which will prolong QT, and at the top of that, teneligliptin will further prolong the QT. So be careful. CV safety, they don't have, many of them, they don't have cardiovascular outcome trial, and you can see I have mentioned the first 4, Sita, Tecos, Lina, Carolina, and Carmelina, Sexa, Sebertimi, as you all know, LO has got examined. Neither Vilda, Tenali, or Evogliptin has any dedicated cardiovascular outcome trial. Therefore, I don't know whether this last 3 drug causes increase in heart failure or not. Risk of heart failure, as you all know, sexagliptin is contraindicated. They are black box warned, and same is with the allogliptin, unfortunately, which is unfair, because in allogliptin trial, there was no increase in heart failure. But the problem lies where there was increase in heart failure in patients who did not have prior heart failure. And therefore, FDA gave them also a black box warning. For Vilda, Tenali, Evo, we don't know. And finally, cost. In the Indian setting, if you see the last 4 DPP-4 inhibitor on the right-hand side, and if you have to choose between this, I would say that the best bet would be to simply see that the DPP-4, which has got a least purple colored marking, is the best DPP-4 inhibitor in the Indian setting. Since you people are wise enough to choose between different DPP-4 inhibitors. Thank you very much for your patience listening.
if you look into the basic pathophysiology of type 2 diabetes, first thing that happens is that you can see that the first phase of the insulin release of the beta cells is not there, and you have only the second. And if you can see that the first phase of insulin release, it will come within 2 minutes of ingesting a meal, and then it will continue to be for almost for half an hour. And this is a very, very important thing. The amount of insulin that needs to be released in the first phase is a very, very important to the postprandial spike which can be reduced. Now, how is it you can prevent that? We have a second phase of insulin. So there are only 2 ways where we can which can secrete the insulin from the beta cells, which is insulin, or we have to have such a diet with low glycemic load, which doesn't
somebody becomes a diabetic today, 160. All of us know that. Now, this is very interesting actually. Monier et al. Has clearly said that if your HbA1c is more than 10.2 and the component of fasting blood glucose contributed to HbA1c is about 80% and postprandial by 20% in Caucasian population. But that is not true in Asian population where they take a lot of carbohydrate. Even in fact, there's several studies have come in the Asian population where carbohydrate intake is very high, not only in India, in general the Asian population. They said even at the higher HbA1c of 10, the contribution by the postprandial is almost 50% of it, not 20 or 30, 25%. So we need to do that even at a high, according to the Monier et al. Study, what they have said is that if you got a high HbA1c, address the fasting blood glucose. It doesn't same. The Indian phenotype is different, the Asian phenotype is different. So we need to address both fasting and postprandial even at higher HbA1c level. The thing is that and a newly detected diabetic who has got HbA1c of 7.3 to 8.5, you can see that postprandial contribution to HbA1c is almost 80%. That's not even in Caucasian population. Even in Indian population, even at the higher HbA1c, there's a 50% contribution. As the HbA1c comes down towards 8 and less, it's going to be 80% contribution. Now, it's very important to note that if you keep looking into fasting hyperglycemia correction, you will ultimately land up in nocturnal hypoglycemia. Instead, when you have such a HbA1c reduction, if you can address the postprandial blood glucose, you can achieve better control of diabetes in the form of HbA1c reduction and also avoiding hypoglycemia. This is what we need to look into that. Now, of course, we can see that the IDF recommends that you can have diets with a low glycemic load. You can use alpha glucosidase inhibitors, and glynates such as rapid-acting insulin secretagogues and short-acting sulfonylureas are also indicated. RSSD clinical guidelines says that very important that 2 hour fasting, 2 hour postprandial should be less than 160, and the same thing like what IDF has said, that we have to have foods with a low glycemic load, and then you can see that the alpha glucosidase inhibitors and glynates, and along with DPP4 inhibitors and GLP-1 analogs are the drug of choice to address the postprandial blood glucose. And now combination therapy with alpha glucosidase inhibitor with other agents may be considered for better control of postprandial blood glucose. This is what we are going to do. So if you look into the RSSD recommendation where we have to go for a combination along with alpha glucosidase, which is a molecule that can be beneficial in reducing the postprandial blood glucose. Now, there are several molecules, but initially I said that if you have a molecule which can address the basic pathophysiology of type 2 diabetes, where if we can restore the first phase insulin release and then also address the postprandial in a different way, and we are going to have that combination. And so use a combination of a drug from different classes which addresses the unmet need of this. Now what is it we can do that? You have insulin secretagogue in the form of ripaglinide, which is rapid in acting and very short acting, and which works for the first half an hour to 45 minutes or 1 hour, and then it will increase the insulin secretion. That's one way. So you can restore the first phase insulin to great extent. And you know that alpha glucosidase, how it works. It reduces or delays the digestion of carbohydrate, assimilation of carbohydrate and absorption into the blood, and so that you can delay the postprandial spike, and so that the second phase of insulin release which is there, which will address the postprandial hyperglycemia. This is what we need to look into that. Now look into the ripaglinide, how it can be better. It is glucose dependent, more physiologically. Higher the blood glucose, it attaches the sulfonylurea receptor and increase more secretion. As the blood glucose comes down, also the action of the ripaglinide comes down. And then you can take that, it is taken along with the meal basically to address the hyperglycemia, and because it's very short acting, it doesn't work beyond 2 to 3 hours, it reduces the risk of hypoglycemia as well. And it improves the beta cell function in patients with type 2 diabetes, and as I said that it restores the insulin, first phase insulin release, and then they are as good as sulfonylureas in efficacy as well. Now you look into the Evogliptin, we know that it inhibits the absorption of carbohydrate, and then most important thing is that the glycemic excursions usually, which is responsible for glycemic variability, will come down, and then most important thing, it is extra pancreatic effect in the Evogliptin because it doesn't work on the pancreas, so that you can see that the effect on the beta cells will not be there, and you can say beyond pancreas, so that it doesn't exert effect on the beta cells and exhaustion will not be there. Another thing is that something like a DPP-4 inhibitor, even Evogliptin can increase the GLP-1 levels, and so that it can also help in restoring the beta cell function, and as well as looking into postprandial hyperglycemia. So now, why should we combine these two? Because two different classes of medications, and why is it different? Because of better efficacy together, and then it can restore, as I said, that first phase insulin release, and then also effective in reducing the postprandial blood glucose, and then there is no evidence of clinically significant pharmacokinetic interactions between Repaglan and Evogliptin when they are combined as an FDC. And these are two different mechanisms, and so that these molecules supplement with each other and give better results for us. Is the treatment for postprandial hyperglycemia beneficial? Well, we don't have any great evidence to say that we know the association, but we don't have any. By treating postprandial hyperglycemia, whether we can bring down is a question mark. But if you look into contemplate from the earlier studies, like for example, if you take the stop NIDDM trial, where it addressed the postprandial blood glucose with alpha glucose inhibitor, it has reduced the hypertension, it reduces the risk of cardiovascular disease by more than around 58%. So if you can look into that postprandial hyperglycemia levels, and then probably it is going to be beneficial. Now, if you look into the Repaglan CV safety, you can see that there is definitely shift towards the left, where it says that the Repaglan is cardio safe compared to any other secretagogues. It seems to be a very good effect on the heart. It doesn't give any cardiotoxicity at all. Now, as far as the efficacy is concerned, we have our own studies by Dr. Manoj Chawla et al. And you can see that they have taken about 200 patients, and then they have taken into two groups, that is Repaglanide with Evogliptin, that is RV group, what we call group A, and where you can see that they have put 0.5 milligrams of Repaglanide and Evogliptin 0.2, and then if necessary, if the HbA1c is more than 8, they've increased the Repaglanide to 1 and kept the Evogliptin as 0.2, and then group B only Repaglanide. Now it's a 6-week study, and then let us look at the results. What has happened was that higher portion, sorry, one more slide. Okay. And then definitely that postprandial hyperglycemia comes down, and then you can see that the proportion of the patients who responded to a combination therapy is far higher compared to 38% versus 52% actually. So you can see that. And there is one more study, this study what is already shown that there is a fixed dose combination of Evogliptin study, and which is about in 20 patients that they have done, and is published in the results here. You can see that there is insignificant weight gain, no side effects such as hyperglycemia, and then you can see that postprandial blood sugar is reduced by 60 milligrams, and that is very, very effective there. So a Repaglanide and Evogliptin combination was effective and safe for the management of postprandial hyperglycemia type 2 patients. There is one more study to look into the efficacy again. This is again a non-randomized, open-label, non-comparative, multi-centric study where 69 patients have taken and put on FDC of Evogliptin 0.3 with Repaglanide 1 mg, and then look for about 3 months, and then there is a significant reduction in post-fasting and as well as postprandial, and as well as in HbA1c reduction has been found. And without any major side effects actually. So are there any other, just because it addresses the postprandial hyperglycemia, this combination has got any other uses, especially elderly population in whom hypoglycemia is a concern, because it has got no hypoglycemic symptom or minimal hypoglycemic symptoms, and then Repaglanide can be used in even in kidney failure. And patients taking low-dose sulfonylureas who encounter problems with hypoglycemia, this is a good choice that you can think. And patients with irregular meat pattern is also a very good choice for us to take. So friends, let me summarize to say that a combination therapy of non-sulfonylurea insulin secretagogue Repaglanide with alpha glucosidase inhibitor will provide efficacy compared to the monotherapy, and both of them have different mechanism of actions. When they're given together, it's got a complementary action and it can prevent the postprandial hyperglycemia and deleterious effects on the endothelium as well. And there are no clinically significant pharmacokinetic interactions between repaglinide and when it is combined as an FDC, and then combination was weight neutral and had fewer hypoglycemias than monotherapy. Before I finish, just to remind you, my friends, that we have, it's a 50th year. It's a golden jubilee year for RSSDI, and then it's a very significant year. I welcome you all for this meeting, which is on September 6, 7, 8, 9, 4 days. We're going to have an exciting scientific session, and very comfortable stay will be there. And then as an early bird registration, it is available as 5,000 rupees instead of 12,000 rupees registration in this conference. And apart from that, if you're not a life member, if you become a life member before June 30th, you'll get the registration free. Just we wanted to increase the membership in RSSD so that we'll be in touch with you. Thank you for your patience.
Thank you, sir, for the wonderful talk. I think with that we can move on to the discussion. So, the audience members, do you have any questions?
Give the mic, please.
The questions for all the three.
Yes.
Yes, you're right.
So one question for Singh on that. In your slide you had shown the IC50 was the lowest for, correct me if I'm wrong. So that means you need, that drug is most potent amongst. So the good side and bad side. The good side is that therefore it will have less of adverse effects because you are needing quite a small amount of drug. But the DPP4 inhibition is 80%. I would have been happier if it was 90% or so. Would a higher dose would have achieved more than 80% inhibition of DPP4, or that is the ceiling? No matter what dose you use, that is the ceiling, regardless of the IC50.
So you have seen the evogliptin and linagliptin is pretty same. That's why they are the most potent and available in a 5 milligram. Both linagliptin and evogliptin is a 5 milligram tab. Now, in their phase 2 trial, dose finding trial, they looked for whether increasing the dose would all further inhibit DPP4. And as you said, there was a ceiling, there was no difference even if you increase the dose to 10 milligram. And therefore, this dose was chosen off. The point is, not necessarily a DPP4 inhibitor should have a DPP4 inhibition of 80% when you administer it. There has to be a sustained DPP4 inhibition over 24 hours of the time. And that's the reason why vildagliptin 50 milligram if you use once daily, their peak and trough effect is compromised if you use once daily. The moment you give 12 milligram vildagliptin, then it the entire DPP4 inhibition remains sustained. Now, a DPP4 inhibition, which is more than 90% when you take the DPP4, but their effect is not sustained by the next 24 hours, HbA1c lowering will be affected. So it's not only the percentage of DPP4 inhibition when the drug is ingested, but it is the entire duration of the time of the DPP4 inhibition. And here, all sitagliptin, linagliptin, allogliptin, evogliptin, other than denaligliptin and sexagliptin, all achieved more than 80% inhibition until 24 hours after the first dose administered.
No,
Right, so I discussed, you are not present here, I discussed before I started my talk. So vildagliptin 100 milligram story is, I would say, little bit obnoxious. You have seen my post on different group. Vildagliptin 100 milligram do not have safety data. As I said in my talk, that vildagliptin initially by Novartis, who is the innovator of vildagliptin, they asked their US FDA approval for 100 milligram once daily initially. But because once a dose 100 milligram of vildagliptin was associated with increasing in liver enzymes, the US FDA returned them and they said that you come back with you divide the dose so that the liver enzymes gets better. And in 50 milligram twice daily dose, LFT elevation was much better compared to the 100 milligram. And therefore Novartis did not came with 100 milligram once daily. I am surprised how could DCGI give them a approval, how pharma company in India gets such kind of approval without any study. I mean, so once you have given to one company, everybody will get that.
No, actually, Dr. A.K. Singh, actually, do you think that there is one saying that, belief that giving 50 milligrams twice a day will have a very good effect on the glucagon, so that postprandial blood glucose is much better controlled with twice a day rather than once a day.
Okay, we had, okay, number of taking the DPP. And
No, that depends on the. I agree.
our own educated, I mean,
Very good. Fine, please.
Sir, I have a question for you, Dr. A.K. Das. Sir, would you...
A.K. Singh,
A.K. Singh.
not
Okay,
A.K.
A.K.
Das.
Singh. Would you summarize in one line as to how do we... So we move on to our next question.
Guts to listen. First, please. Okay, sir. So as you say, one need to understand. Useless, idiotic argument in the... Don't create unnecessary in the hall. You know nothing. Huh? You know nothing. Your registration should be revoked.
Thank you. Sir, my next question to you. Sir, would you summarize in one line as to how to choose one DP4 inhibitor over the other within the class?
There is no one line, right? So we are learning 2006 once the one liner to choose. You have got some pros and cons associated with the different DPP4 inhibitor. Now you have got a data with the US FDA approved DPP4 inhibitor. Sitagliptin has undergone a CV outcome trial, it was neutral. Linagliptin has undergone a CV outcome trial, it is cardiovascular neutral. Sexa has gone neutral, signals of increase in heart failure. Evogliptin has undergone CV outcome trial, neutral, some signals of heart failure. The DPP4 makers, I mean when you're talking about Tenaligliptin or Evogliptin, they don't have any dedicated CV outcome trial. So we don't know yet whether these drugs have got any potential to increase in the heart failure. So simple suggestion, if you have got a patient with known heart disease or a known heart failure, don't use the drug which has not been studied. So these will be a typical patients where one should use either sitagliptin or linagliptin if you have got established cardiovascular disease. If your patient do not have established cardiovascular disease, you can choose between any cheaper gliptins provided they do not have a QT prolongation issues.
So for short of time, we would just close this session. Yes, we can discuss during the coffee time.